Welcome to Autism Knows No Borders, a podcast where people connected to autism inspire change and build community. Together with the Global Autism Project, I'm your host, Rachel Harmon, a professional with over a decade of experience in the field of autism services, outreach, and advocacy. Can applied behavior analysis ever be done safely? Dr. Shelby Dorsey, a BCBA late-diagnosed autistic ADHDer and mother of 2 neurodivergent children, believes yes. If you'd like to learn about a safe and personalized approach to autism services, stick around for part 2 of my conversation with Shelby. Among other things, we discuss the harm that can arise from traditional ABA practices, what it means to be happy, relaxed, and engaged when learning, how being autistic herself helps Shelby relate to her clients, setting goals for her clients only when they're an issue for themselves, not just for society, how to create safe and effective ABA interventions, the importance of welcoming new and diverse ideas, and resources for clinicians seeking to improve their practice. In this episode, discover what's possible when you give room to grow. And now I present you Dr. Shelby Dorsey. Let's talk about your work as a BCBA and what your approach is or your philosophy when it comes to working with families.
I like the phrase safe ABA. I don't hear people using it often, but I like to talk with parents about safe ABA. Safe ABA is basically ensuring that everyone that is participating is in an environment where we are not causing harm, doing harm, reinforcing things that might harm. And as a BCBA, we're looking for those things in the environment. So it's not as if we don't know what those are. We're assessing the environment to say, this thing might be increasing behavior. I don't want to do that. I want to look at context. I want to work with the family and with the child. When I'm assessing a family, I am looking at what skills does this person not have that they need to thrive in their environment, not my environment, not your environment, and I hear this a lot, like same age peer, where it's like, okay, every 5-year-old does this, so your 5-year-old should. That's not the case always. So approaching it in a person-centered way with the context of the family, the culture, the safety of the client and parents, the safety of the RBT, and starting there. Always starting from that point, because we do have documented history of ABA being extremely harmful, ABA causing post-traumatic stress disorder in its clients and its therapists. I've had supervisees, RBTs, therapists who have had things as serious as a traumatic brain injury from keeping a client in a hold for hours.
Wow.
And then something happens, someone falls down. Before you know it, this young RBT has a TBI from doing a protocol that I would never recommend anyways, on top of the fact that they were alone with a person, all of these things. It's not safe. That's not. And if we're not safe, it's kind of like when I was in college, I was in education. We talked about like the Maslow's hierarchy of needs.
Yeah.
And I, reflect on that too, as we're going into, is everything met? Where are we at? And then also with each participating partner. And I think that it is a huge mistake for BCBAs to practice ABA without considering the context of how harmful it has been or could be.
Mm-hmm.
I think it's a huge misstep to not acknowledge that and to not teach families how to identify that. I may not always be your BCBA, but if somebody wants to hold your kid down for 2 hours for not complying, that's not safe ABA.
Mm-hmm.
Get them out. Go somewhere else.
Yeah. What do you say to people who are anti-ABA completely? Because, this has been very controversial within the autistic community, rightfully so. And I remember when I had I'm a BCBA also, and when I had my kind of reckoning with the field and woke up in a way, because I was trained back in the day, like before there was even an RBT, and I was trained to teach compliance and eye contact and all those things that now I'm there. I went through my whole processing of being ashamed and everything and the guilt. But now I'm trying to use the podcast actually to shed light and educate people about the harm and also the more kind of reformed ABA. So anyway, what do you say to people, autistic people specifically, who are like, no, any ABA at all is harmful?
I say that's valid for you to think and feel that way, especially if you've had personal experiences with bad ABA, because to me, that's acknowledging how powerful the science is. And to me, I've studied education, and I've studied my master's degrees in counseling. And I was originally going to I wanted to be like a clinical therapist, like a clinical psychologist. And so learning about the different methods, to me, when someone says like no ABA ever, it reinforces how powerful ABA is, because it shows how wrong it can go. That's how powerful it is. And I think that's a reframe that not a lot of people consider, is that for something to be that bad, it has to have that much power. And then acknowledging that it does, and then learning from the person. Is that from personal experience? Is that from, things that you've heard or read? And then I try to have the conversation, especially if I'm with an autistic person. Very few things are all bad or all good, especially if it is a tool. And ABA is a practice guided by applied behavior analysis. So it's a set of interventions, it's a set of techniques, and the way you apply those is actually the good and the bad. So when you think about, is any tool set ever good or bad? Not when used correctly, not when used safely. A hammer, if you only heard about people dying because they got hit with a hammer you would think that's stay away from me from a hammer. But if you saw that hammers were also used to build shelves, you can have that duality. And so acknowledging the duality and acknowledging that the ABA is only as good as the provider, it's only as good as the context that it's in, and that if I can convince, or if I can, and I don't really even want to convince, but if I can explain, you're right, that was bad ABA. I am sorry that you had to experience it. I'm sorry that you had to go through it, because these things, they caused harm, and we should not, if we're causing harm, we need to back out. But there are also, as an autistic person, there are practices guided by ABA that I use in my everyday life with my children, with myself, that have empowered me in a way that no other therapeutic medium has been able to. Because it's a science of consequences, because it's a straightforward with definitions, it's like a hard science, like physics. To me, that helps me wrap my head around it. And then that also helps me use it in ways. And so if I can get that far in a conversation with an autistic person that's like, no ABA, then usually we can eventually get to a conversation of, okay, wait, why have I never heard this before? Why are you the only person saying this about ABA? And then going, I'm not the only person saying it about ABA, but we're in an era of trying to reform it. So I can't promise you aren't going to experience harm, but I can teach you about what harm looks like and how to point it out, how to tact it, how to get out of the situations. And then also, now that you know, hey, build awareness within your ABA group. And so, at least in my experiences so far, that has been the most helpful tool, is just acknowledging, yeah, it's powerful and it can be bad. But if we look at it from, we do not want to cause harm, we want to stay safe, we want everybody to stay safe, then you're taking a lot of the risk out of it because you're adding a lot of safety to it.
Yeah. Can you give a few more examples of what harm looks like? Because you mentioned like holding someone down, forcing them into compliance, right?
Yes.
What does that look like if it's being done with harm? And what does it look like when it's being done safely, like a program or something?
Mm-hmm. So I like to operate on what I call a mood scale. And so happy, relaxed, engaged is where learning occurs best. I have a couple of t-shirts that say that at the SD store. So if we're doing skill acquisition, then I want the client to be happy, relaxed, and engaged. If that's what we're doing, skill acquisition. Any intervention, any program, any procedure that takes them out of HRE, it's not going to be safe for skill acquisition. Why? Because I know that learning occurs best in HRE. Now, can we keep a client in HRE for their whole life? No, but not everything is direct learning, like direct teaching, like we do in ABA. So what that may look like for my client is when my client starts getting agitated or aggravated, I have some behavioral definitions that my RBT can say, okay, when the client starts, I have this, my oldest daughter does this thing with her eyebrows where she will squinch them up and go back, like up and down. And she's starting to get agitated when she starts having facial tics. I've noticed so many clients have like a grimace, or they might bite down on their teeth hard. They may stim more when things, when they're having like a reactivity to an input of some sort. And so when you see that, that's when I want to analyze the behavior in that moment. I never want it to get over and above. And so people who work with challenging behaviors, high magnitude challenging behaviors, we work a lot on getting to HRE before we introduce skill introduction. Like before we introduce skills, we have to get into a place where we can learn. And I get criticism for this sometimes, but it's very clear that learning occurs best when you're in HRE.
What's the critique? That it takes too long to get there?
And you may be reinforcing high magnitude dangerous behaviors. But my argument is, but we're not. We're taking data on those behaviors. So if they're increasing, we need to reevaluate how we're reacting. But if that looks like for 2 weeks, a client comes in, sits on a beanbag, and does preferred activities until we can get into HRE to get skill acquisition, that's okay. I'm not in a rush. ABA is not fast. I tell every parent, I tell every RBT, I'm not quick. This isn't fast, and I won't push fast, but it is specific. It is, are we here? And so I will also ask when I'm doing an intake or an assessment, what do they like to do the most? What could they sit and do for hours? And with some clients, it's iPad. Okay, well, let me watch them on the iPad. What does that look like for them? What does HRE look like for them? I had this client who had cards, and they would just like shuffle the cards in their hand, hours. And so parents wanted me to like come in and take the cards. I'm like, not a chance. And here's like just a funny tidbit, or at least I think it's funny. When I started like really pushing this, when I got my confidence behind me as a clinician and was like, no, I don't do response cost. I don't do punishment procedures. My RBTs don't put their hands on my clients. And I work and have worked with high magnitude, severe behaviors, eye gouging, self-injurious head banging. There are ways to address those behaviors without putting a child in a hold. And one thing that I say is over my dead body. And I got some criticism for that, of saying like, Shelby, like, don't say that. I'm like, that's how serious I want you to know that it is that I'm not letting you touch my clients unless I'm gone. And like, once I started really pushing it, everybody's like, okay, well, I don't really believe that you can get this behavior decreased without a hold. And I'm like, I don't need you to believe it. I'll just do it. And then there we go. We're both happy. And now the kid's not eye gouging, and it works, but it is slow, and you do have to work in stages. And so, watching the cards, watching stimming, watching iPad, and seeing that reinforcement and then defining what HRE looks like is so powerful. But I tell this to parents, I tell this to RBTs, if I was working on something and all of a sudden somebody grabbed me up, held me against my will, and when I start trying to get out, they say, calm body, calm body, Shelby. That would make me go harder.
Yeah.
Restricting me doesn't make me calm down. And it doesn't really anyone. If you just grab up a kid, a neurotypical, anybody, everybody's kind of like, what are you doing? Yeah. And I don't think that because autistic people sometimes don't have the same social reciprocity, that clinicians will not acknowledge that nobody wants to be grabbed up. Mm-hmm. So let's not do that to anybody. And so I also have this clinical rule, like, if you wouldn't do it to me, don't do it to my client. RBT, parent. And parents are a different story, because there's so much pairing that I think needs to go in to your parent trainings and the family, because you really have to get to know people, because you're shaping your kid's life. It's a huge deal. It's a giant responsibility. Yeah. And I don't want someone shaping my kid in a way that I don't see value in, or that I find troubling. So you really need to get to know your parents. But once that rapport is established, I will say that, would you do that to me? And especially if I'm if you're in person with somebody, I've seen, RBT like hold a hand, like a kid will want to grab something, and instead of blocking or redirecting, it's like, and I'm like
hand over hand. Yeah.
Yeah. Do that to me while I grab my phone. I'm the director of clinical services, quote unquote, the boss. Do that to me. And they're always like, I wouldn't. Okay. I know you wouldn't. Why? Because I would say, what are you doing? Get your hands off of me. This client does not have the ability, either vocally or hierarchy. They're a 4-year-old. When a 4-year-old says, get your hands off of me, you don't. Now, if I was running into a street and a car was coming, would you grab me? Yeah, you probably would. And I understand that. If my client is running into a street and you need to grab them up, that kind of gives me chills, because I have had this happen. But like, that's when you use the very last instinct, which is just hold on. But in no other context do you grab a person. Do you withhold a person's own body movements? Not even in prison. So I don't know what makes people think that that's a good choice in ABA, but I think that they're scared and they don't understand. They're looking at the self-injury behavior, like eye gouging, for example. It's really traumatic to see. So your first instinct might be like, move the hands, pull the hands down, hold the hands, do a hold, where it might be, there's gloves that kids can wear. There's, I've had kids do pillows. I even had a kid put glue on their forehead, and they would scratch the glue off because they wanted to scratch their skin.
Yeah.
But I'm like, let them scratch the glue. I will put Play-Doh in their hair. What does it matter? Like, they're not hurting themselves. We will shape the behavior. But we only can take like a centimeter right now. And that centimeter is the difference in harm and safety and being safe, we're going to take that. And so that's where the kickback comes, because it's a slower process. It's a more difficult process. It takes more training on your RBTs, where they have a fundamental understanding of what is safe, what is harm, have a fundamental understanding of what is assent. If you are training RBTs and putting them with clients and training RBTs and putting them with clients, and you're not having these kind of conversations, then to me, that's when you open yourself up as a clinician to harm. And if you harm, I feel like you're taking us back. You're taking our science a step backwards.
Mm-hmm.
You're taking away something from the autistic person that you're helping. When you create harm in a therapeutic setting, you wouldn't say it was okay for your therapist who does CBT or cognitive behavior therapy if they harmed you in your first session, or if they grabbed you, or if they said, you know what, actually, I'm taking $5 away from you because you were late today. You'd be like, I'm not coming back.
Yeah.
And ABA doesn't reflect on itself enough to me. And so in my work, clinically, when I speak, when I train, I always try to make autism more personable by telling about my autism, by telling about my kids' autism, and then by being like, would you do it to me? Okay, no. Would you do it to this? No. Okay, we're getting there. And which is interesting to me, because when we go back and we think of autism and we see something like social difficulties in maintaining relationships, or difficulty in imaginative play, or, deficit in social communication, it's always interesting to me, because to me, neurotypical people have deficits. Like culturally, we have a big deficit in social communication, where things are supposed to be like understood, but they're not genuine.
Mm-hmm.
Professionalism to me is one of those things. Like professionalism is typically not genuine. And if it is genuine, it's just kindness. But when we get rigid about what professionalism is, we exclude people like myself, people with other neurological disorders, people with learning disabilities. And to me, not understanding that is a deficit in social communication.
Right. When on the other side, you have people who are sending text messages in meetings about other people at the meeting.
Yes, exactly,
and that's
Rachel. And it's
not labeled unprofessional.
And that's no one said that person had a persistent deficit in social communication.
Yeah. Shelby, question about your
Mm-hmm.
practice. So did finding out about your autism change how you deliver services, or was this always kind of the way you worked?
Always the way I worked. I think the discovery and the diagnosis was more being able to personalize it by using myself as an example. I was very, very, very fortunate to have an amazing supervisor that shared this philosophy 10 plus years ago and allowed me to work it out in my therapy as an RBT. And there's a really great article called Behavior Artistry, and it's by Callahan out of UNT, University of North Texas. And it talks about the artistry of a behavior technician. And that was such an important article for me. And it's still important in my training and my supervision, because there is an art to reinforcement, to pairing. There is a smoothness in which you can interact with your clients. And that was always easy for me. And then when I was diagnosed with autism, I had a lot of people say, basically, that before they were diagnosed, it was always like, you're so good with autistic people. And after your diagnosis, it's like, well, because we're all speaking the same language, and maybe the parent is neurotypical, or maybe the other BCBA is neurotypical. So they're the ones not speaking the same language. But I don't think I've ever had a client that I didn't like or didn't like me. or at least we found a mutual respect, but there's some understanding of the social approach.
Yeah.
And everybody's own timing. There's sometimes a forcing back and forth conversation, forcing sharing interest, forcing a certain emotional affect, forcing a social initiation that I see in neurotypical people that are really uncomfortable and actually like follows the DSM criteria, like go down that. But that's what we ask of immediately. We're wanting conversation cards, or we're wanting, ask someone what their interest is. When in reality, I think if we focused on a more like a safe approach, a values-based approach, what does the kid value, the family value, as a team, then you can actually work on the deficits that are affecting the person. And you have an understanding of, I may not share interests with everyone. Everyone may not want to hear me talk about ABA for 90 minutes. Maybe Rachel does want to hear me talk about ABA for 90 minutes, but maybe somebody at dinner doesn't. Maybe my cousins don't want to. Instead of forcing some kind of conversation or feeling that I'm not good enough at conversation because I'm not hitting these cues that ABA tries to teach. When somebody walks in and says hello, do you say hello? Do you clarify? When someone looks confused, do you know what someone confused looks like? I think those are all important, and those are a way to get through life. However, what is the person battling? How can they get through it? And then we can come back and focus on those social communication deficits or those restricted repetitive behaviors, if and when they are an issue to the client, not because they are an issue to society.
Yeah, that makes sense. Hey, Rachel here. I'd like to thank one of our listeners, Izzy0826, for reviewing the show on Apple Podcasts. They said, "Thank you for having conversations that will help people grow and think beyond stigmas and misinformation. Thank you for the kind words. 5-star reviews like yours help us to continue spreading autism awareness and acceptance around the world. If, like Izzy, you're finding value in Autism Knows No Borders, please leave us a review wherever you get your podcasts." And now, back to the conversation. I think you are hitting these points that some autistic people might not have the words or know how to describe it. So it's so important to share this message.
I get chills when you say that, because that's the whole goal. When I go on podcasts or when I talk to people, I have a t-shirt company, but all the time it's like, well, what do you sell? Do you have a book? Do you have a da-da? And I'm like, I'm just trying to tell you, because it's a communication disorder. So if I have the disorder, but I also have the ability to communicate in some way, what it's like, what it feels like, then I can at least give examples.
Yeah.
And that's really important to me.
Yeah. Okay. I'd like to close with one last question. So usually I ask people for advice that they want to give to a certain group. Like if it's a family member or a parent, they might have advice for other parents. But you have this unique perspective again of wearing all different kinds of hats. So what group would you like to give advice to, whether it's other autistic people or other clinicians or other parents? What kind of is calling to you right now?
This is so funny because it kind of goes into the social emotional. I don't really feel called by an outside source. I don't feel like there is a certain group and they need me to say something. I think more so what I've experienced, what has gone well and what hasn't gone well. And when something hasn't gone well, that is like a ding, ding, ding. Hey, we should talk about this. And so as a whole, something that I'm seeing become more important in what I say is talking to everyone about neurodivergent professionals, adults, and interacting with them. And the message that is so important to me is the diversity of ideas is so important. The diversity of people is what makes things beautiful. It's what makes things interesting. And when I'm in this space and we're talking about interventions and ABA, there's a lot of fix it mentality instead of allowing space to grow and advance. And employment is difficult for autistic adults, whether you have a PhD or you have a GED. Statistics show that. Meetings are hard. So if you're out there and you're listening, when you are working with people or coming across individuals, maybe you have a supervisee, maybe it's a parent, maybe it's your clients, but understanding that the deficit model highlights and empowers the deficits, and what you take data on, you will see more of by definition. So are you just looking at the deficits, or are we looking at how the set of behaviors has worked for the client? What is just society and cultural standard and not important? And then if the person has a skill set, has XYZ, but maybe they have some growth that needs to occur in a different spot, being creative and allowing that growth before punishment, before overcorrection. And this happens before response cost. This happens to adults at work. This happens to adults at doctor's appointments, in parent trainings, where we tend to punish first because it feels best to us. And I say that very lightly because punishing other people doesn't feel good to me, but I am very familiar with the definition. So I kind of have this idea of what coercion feels like from another person, and I can avoid that. But when I'm watching, you do see that punishment can reinforce the punisher first, and really understanding that you need to break that habit to be safe for any neurodivergent person, any person that's brain is different, any person that thinks different is, I like to say, like wired different. And if you don't have that approach, if you don't have that growth approach, that contextual approach, that who is this person approach, then are you causing harm? And if you are causing harm, even a little bit of harm, why are you here? Why are you in this space? Why are you in a person's home? Why are you shaping a child's life? If you know you're doing even just a little bit of harm, should you be there? And my answer is no. I believe that you can do it without harm and be successful. Not just do it and be okay. You can be successful, but it does. There are. It's harder. Mm-hmm. Takes longer. It's more intentional. It requires a higher skill set. So if you're listening, think about if you are causing harm, and if you are, why are you doing it? Really self-reflect, and what else can you do? You don't have to. And programs that produce BCBAs that have a kind of an underlying of like, yeah, it hurts a little at first, but then it's okay. Doesn't have to. And if you are getting that message, then maybe you're listening to this podcast so that I can be the one to tell you it doesn't have to be like that. It shouldn't be like that. And it can be successful without harm. But as long as we allow even just a little bit of harm in our practices, then we open the gate for unchecked harm. And that's why we have a bad reputation. That's why you do have people that are anti-ABA. I mean, how many people do you know who are anti-cognitive behavioral therapy? Mm-hmm. Few. You might say like, it doesn't work, or I didn't do it, but you don't have a hate group in every, things like that. Yeah. physical therapy. You don't have hate groups for physical therapy.
Right.
But ABA is very powerful. And we have to understand that human growth does not require harm from an intervention.
Mm-hmm.
And that's really just really big to me.
Where would you point clinicians who are looking to do better? Like, what are some resources?
I have found a great community on Instagram, and I love online communities. And Facebook groups, they're just not for me. I find them to be toxic. I see a lot of people spend like, oh, this Facebook group, has all these BCBAs and all this information. And then it's just people arguing about, like, can you drink a coffee from your client? Or arguing about, do you need a 2 weeks notice or a 30-day notice, when the BACB doesn't mention either. But on Instagram, I found a really powerful community. So APBA is the Association for Professional Behavior Analysts. I find a lot of strength in that organization. I find a lot of resources. I find a lot of like-minded clinicians. I find leadership. The CEO, I guess she's maybe CEO and president's name is Tyra Sellers, and she does a lot of work to be, I'm going to say, like, quote, quote, on the right side of history. To progress an organization in that way. I also find a lot of value in WEBA, the Women in Behavior Analysis Organization and Conference. Find, again, a lot of like-minded people. The BABA, the Black Association of Behavior Analysts, that's a great organization that, if you are looking from an organization perspective and you want to get around people, like, okay, I'm a BCBA and this is something that I want to get into. Those 3 organizations are organizations that I find a lot of value in. And then when I go into those organizations, I see who are their speakers, who are their members, who are their volunteers. Going to those conferences makes me feel less alone because I meet in a room of like-minded people. And sometimes being a behaviorist, being a BCBA can be quite punishing if you are just around the internet where you're in anti-ABA groups and things like that. It can be very punishing. So getting into a space where you're talking with people in real life and you're interacting with these people are very helpful. There is a new book out. The authors are Dr. Madi Serta, Meg Solomon, and Jen Ferris. And the book is called Reframe.
Madi's been on this podcast.
She's my favorite.
Yeah, I like her a lot.
If you were going to follow one person on the internet, I would say she's a great one to follow.
Yeah. And you too.
Well, thank you. Yes. Follow me at Dr. Shelby Dorsey. But that's where I would start, in those organizations. Okay. And you can find people and then branch out for your specifics. If you're in OBM, if you're in clinical ABA, if you're in performance and exercise science, if you're in clinical leadership, you can kind of go into that. If you're in education, you can go into those organizations that promote the rethinking, the no harm ABA, and then you can really find your people within those organizations. And then in the internet community, finding a community that reinforces what you're doing, that helps you not feel alone.
Yeah, so important.
Mm-hmm.
Well, thank you so much for sharing all of your insights. I think this is going to be a really, really helpful and impactful episode for people.
Thank you so much for having me. I've enjoyed it, and I can't say this enough. Thank you so much for being flexible. As much as this episode is everything else, those things really matter, because you easily could have been like, I can't get to you. I'm sorry. We're not going to be able to do it, or something like that. And then that's one less autistic story that's out there.
Yeah.
So it's really impactful when people just are able to accommodate small things. So I appreciate that.
Of course. Yes. Thanks for tuning in to Autism Knows No Borders. If you enjoy this podcast and you'd like to support our mission, please take a moment to rate the show and leave a review. You'll be helping us to continue spreading autism awareness and acceptance around the world. Thanks for listening. Take care.